this is an ancillary interested project that I have approached somebody about a couple of years ago, or almost a couple of years ago. And it just turned out to be a very fine opportunity to develop into a full-blown project. Let's go ahead and get started. So this is the team that I have worked with for this specific project. 3 graduate students from various departments, but non-public health, so computer science and computer engineering, and a couple of professors from Department of Medicine and Department of Surgery. Particular to note is none of them actually have any clinical medical background, but they do research using machine learning and data visualization and data science projects. So it was a great adventure and endeavor, and I'm still in the process of learning from this interdisciplinary collaboration. Just a bit of outline about the background of this work and how it started, methods, results, and conclusion. So to give a little bit of background about social determinants of health, I'm sure as public health professionals, we all are aware about the implications of social factors that are way beyond the control of an individual. So conditions in which people are born, grow, live, work, and age. This is the typical phrase that World Health Organization and CDC and many other eminent organizations use to define social determinants of health. The most important part of social determinants is the complex interaction of these factors, which tend to go beyond an individual's control. And when taken as whole, they possibly have greater impact on population health than the biological, behavioral, and healthcare factors that most of the research generally focuses on. So as we have noticed recently, this has gained a lot of attention, not just in healthcare, but literally across human health research. So it's very important we incorporate these factors into public health research specifically at every stage, starting as early as thinking about what can be done, like how does a research idea start? And it's even more important to identify ways in which these findings can be transformed into actionable items, let it be local policy stakeholders or even regular public use, how well we are informing the public. Historically, social determinants of health have been measured using a single easy to understand measure, like let's say, or is a family living in poverty, or what's the educational status or employment status. Not just at the individual level, even when considering these factors at an area level, meaning within the neighborhood, what is the percentage of population that lives below poverty? What percent of the population has less than high school graduation, or metrics that are representative of just one factor, like let's say income, education, things like that. Slowly, more recently, we are seeing conceptual frameworks that are incorporating a wider range of these indicators, or even creating cumulative indices that try to capture various dimensions of these social determinants of health. They have been developed, they have been broadly used for a wide range of applications like data collection, clinical use, or research in general. But let's not forget the bigger challenge with meaningful interpretation of these indices. While they are very nice to incorporate into modeling techniques and coming up with association studies or hypothesis generation studies, how valuable are they for general public or for stakeholders who are not in the public health research or research in general? How well do we inform them? So the work by Christine et al., Shao et al., Messer et al., and many more have used these cumulative indices, which are very well informing us about the possible ways that social determinants of health can impact population health. But the main caveat or the main challenge is the unique characteristics of these neighborhoods and also the geographic heterogeneity, meaning let's say we take a very diverse immigrant area, for example, maybe the New York City. You could have people from the extreme ends of income scale, very low to very high, and also across the spectrum of employment. And they could be very diverse in terms of ethnicity and their immigration status. So in such a diverse population, how well can a single index do justice in describing the geographic region or the population characteristics? Or let's take an example of very deprived regions in the Mississippi area. Just imagine the compounding or the intersectionality of various dimensions of disadvantage, meaning let's take up a county which has very high percent of population which are non-white, and they also have low income. They are also living in poverty. Let's imagine the implications of the compounded effect of all of these factors. So all this to say that it might be very difficult to use a single index to characterize a specific geographic region and to use it in day-to-day life to describe health outcomes. So this whole project has been primarily based upon work by Marianne Kolak, who is a geographer. Very interesting work of hers shows that she actually created a multivariate index that I have been referring to till now, which accounted for more than 70% of the variability in various social and economic factors within a geographic region. She further used this information to identify groups of census tracts, meaning she bucketed all of the 74,000 US census tracts, the geographic unit, into 7 groups to identify and characterize them. These are broadly the variables or the measures that Kolak has used, which can be defined using the socio-ecological model of health, where you have individual factors, which most of us have been focusing for a very long time, and the factors outside an individual, where you can see what is the percentage or the age composition of the area that they live in, what level of the population in that region has proficiency with English speaking, or what's the family structure, or what's the racial and ethnic background of the population in that region. So things that can scale out or pan outside of an individual to the level of the whole community. And this is the single image that has really drawn my attention to this project. You notice how she was able to identify 7 different types of census tracts, rightly labeled as rural affordable, suburban affluent, and so on and so forth. See how majority of the country is rural affordable census tracts with clusters of suburban affluent in the Northeast and the Midwest, and multilingual working class in the Texas region, whereas most of the southern belt has been heavily rural and affordable. But it's important to note that this is a very zoomed out version of it. And as we go deeper into this map, we can realize that there is a lot of heterogeneity even within the small regions. Like the inset is showing the Chicago area, where you can see all the 7 types of census tracts in such a small geographic region. All this to draw attention that using multiple single measures, we can always try and see if there are patterns of distribution of these measures to identify common geographic units in the US, and to use that information for directing policy. That's the broader aim of this project. So what interested the image that I previously showed is that you see that the whole Northeast was being grouped into one set of census clusters. And majority of the Texas was being clustered together as one group. What interested me was that if I can focus on a region, a specific census region, let's say South, and repeat the same process, would I be able to identify a different pattern within the South? To bring in and identify if there is something we can help with regards to the stroke belt or the diabetes belt, to identify factors that are in the South that can highlight census tracts which have even higher risk compared to the rest of the country. With this idea, I approached Dr. Ramraju in the Department of Surgery because he's a machine learning expert, and I wanted to see if there are ways that that are data-driven to identify these patterns. I did this in 2019, and then COVID happened, so this was tabled for a while. And then around mid of 2020, UAB's Informatics Institute has come up with this opportunity called as the Data Science Hackathon, which gave us 48 hours to do as much analysis we can using whatever data we want to come up with innovative ways of helping the research community inform about COVID-19. And that's when Dr. Raju has approached me saying that, well, you had this idea, would you want to expand it to involve COVID data as well? And moving into later into the year, AHS announced this COVID-19 data challenge, which was similar along the lines of what UAB's data hackathon was about. Like, just use the data you can, come up with a solution, or if not, at least come up with a way to inform the community or the research community about possible ways to approach this pandemic. And we saw this as a new opportunity. So given that we have data that's being collected on a daily basis about COVID incidents and deaths, we thought we could use information at the county level to identify county typologies across the US using the various traditional social determinants of health measures that I previously referred to. But we wanted to add on to it, add additional measures to the same method, which might be very relevant to the dynamics of the SARS-CoV-2 virus transmission. And once we are able to identify the typologies, we wanted to describe the COVID-19 mortality among these groups of counties. So the data we used was for 3,140 counties. We excluded those which had missingness. At various measures, we included only continental US, so we did not include Alaska or Hawaiian Islands. We used data from the Census American Community Survey, the 5-year estimates for years 2014 and 18. And Johns Hopkins University, thanks to them that we have a robust resource of regularly updated COVID data. And also thanks to another group at Johns Hopkins, which have maintained a GitHub repository of various county level measures that seem to be very relevant for this pandemic. So in the first step, we identified 23 county level measures that seemed relevant to the pandemic, and then we did dimension reduction using exploratory factor analysis. After identifying some inherent latent factors with these 23 variables, we used unsupervised clustering methods that identified patterns of data distribution within these latent factors. And in the third step, we visualized the mortality rates by these county types. So the traditional measures we included were pretty much reflective of many measures that are used across multiple previous studies, which broadly included socio-demographic factors like percentage of non-white population, the age distribution, and what percent of the population is disabled. Also economic factors like per capita income, percent living in poverty, and housing and transportation related factors like percent crowded and percent who are paying major portion of their income towards rent. However, those were the traditional measures that were generally used for chronic health outcomes like diabetes or hypertension. But for the infectious disease dynamics, those may not be enough. So we considered these variables which reflected the health of the population, as well as some characteristics like density, net migration across the counties, and the percentage of population that lived in rural areas. So coming to the results, once we identified these variables, we first did a two-step approach. In the first step, we just did the exploratory factor analysis using the traditional measures, where we identified 4 factors that explained over 60% of the variance. The 4 factors we were able to identify that the first one, socioeconomic characteristics, was accounting for majority of the variance. Moving on, we had family and housing characteristics. For another factor, immigrant characteristics and the age composition of the county. The unsupervised clustering, we used K-means, which identified 5 county typologies based on these 4 latent factors that we observed. So this was the distribution, or displays the location of these various county typologies we identified. And as we can see on the left bottom of the screen, the blue color represents the socioeconomically advantaged, purple disadvantaged, yellow is majorly white and elderly, whereas pink is working class, and green deprived immigrant. A word of caution about the nomenclature is that it was a difficult exercise for the whole team to come up with these names. We looked at the distribution of each individual measure, as well as the latent factors we identified after the dimension reduction. And it was hard to capture all of the information into just a 2 or 3 worded category, but we tried our best. So to characterize this across the US, we had more than a quarter of the US counties, which were mostly white, had the age of the population of these white communities, meaning the ones in the extreme Northeast, along Kentucky, Virginia, West Virginia, places like that had majorly white population, and they were old. Whereas if you look at the South, we see how it's clustering together in the socioeconomically disadvantaged, the violet color. And this, again, is as it has been expected for many years, that this is the belt, the diabetes belt, stroke belt, and potentially even the heart failure belt. And Texas, again, as expected, Texas and California were clustered together, with high majority of the population being non-white, non-English speaking, who had less than high school education, so on and so forth. So it was interesting that even at the county level, we see how similar many of the counties are, and as expected. So even though we used more than 15 variables for this, for identifying these clusters, I tried to just include the 4 which really stood out to us, where we see on the top left corner, the percent uninsured population is particular. These are, sorry, let me say, these are kernel density plots, just showing the distribution of the individual measures. So the deprived immigrant, the blue line, and the socioeconomically disadvantaged, the black line, is showing that a higher proportion of the population within those counties is uninsured. Similarly, on the right, we see the percent population with limited English proficiency. Again, we see the deprived immigrant and the socioeconomically disadvantaged are on the higher end of this distribution. Particularly to note is the high school, less than high school education. So the percent population which had less than high school education was particularly high in counties that were considered deprived immigrant. And so the ethnic distribution, who are non-white, is also higher in the socioeconomically disadvantaged and the deprived immigrant. So this is like a cheat sheet that our team used to identify patterns of distribution of the latent factors that I previously mentioned across the various county typologies. And the socioeconomic characteristics and the family characteristics really stood out for the socioeconomically advantaged and the disadvantaged, and it was easier to identify these two groups. And the immigrant characteristics was heavily influencing the deprived immigrant cluster, whereas the remaining groups were kind of all over the place. But looking at the maps, we were able to see patterns. This is a very busy table, but I didn't know how else to display all the information that's required. We can always come back to this if people have questions about it. This is just showing the distribution of all the 15 variables that we used in the traditional SDOH measures and the typologies. And now for the second layer of the analysis, we added another 8 variables to the original traditional variables which were relevant to the SARS-CoV transmission, the net migration, population density, percent population that were smokers or obese, things like that. In this, we required 6 factors to explain about the same variance like the previous step, and they were pretty much following a similar pattern like the traditional, but what stood out most was the population density or the urban core characteristics. And through this method, we were able to identify 6 different county typologies. It looks pretty similar, like the new typologies based upon adding those additional few variables to the analysis. You still see that the Southeast is still having the socioeconomically disadvantaged, but what's more interesting is that they also had poor health. And previously, the region in Kentucky, Virginia, and West Virginia, which were identified as majorly white and old, also started clustering along with the socioeconomically disadvantaged and poor health. And it's expected because as you age, you tend to have all of these conditions at a higher prevalence of these conditions in that population, so they tend to cluster together. And the socioeconomically advantaged in general still remained in the Midwest. The deprived immigrant also had poor health once we started considering those factors, and it still remained in Texas and in California. And the working class, like in the previous, is also more heavily focused around the New Jersey, New York area, and also around the Chicago area. So what's particularly to note, and it's hard to visualize in this specific map, is that there was less than 0.5% of counties, 13 counties in particular, which stood out, and those were the metropolitan core areas. It was amazing how the K-means clustering was able to identify this group of counties which were extremely densely populated. And in a minute, I will show you how that's very relevant for COVID. So the counties included DC, District of Columbia, San Francisco County in California, Hudson County in New Jersey, and the whole New York core, which is Bronx, Kings, and New York, Queens counties. I wish I could have shown you zoomed into this, but right now I do not have access to that. So sorry about that. And this is the cheat sheet that we use, similar to the previous step, where we tried to identify the names or how these factors were distributed across these county typologies. Also, the distribution of all the individual variables, this will be here, and we can come back to this if anybody has had specific questions. And similar to the previous approach of using traditional measures, we saw that the deprived immigrant and socioeconomically disadvantaged were clustering somewhat to some extent, but metropolitan core areas were the outliers that were driving all of this clustering. What's important is that the counties were still able to cluster similar to the traditional measures that we used in the previous step, but metropolitan core was just standing out across all. And one interesting fact was that the percentage of population which had fair or poor health was particularly high among the deprived immigrant and the socioeconomically disadvantaged. Okay, so this is the most interesting aspect of it. This map shows the mortality rate per 100,000 population, COVID-19 mortality rate, starting in March when we had like the initial case, and then how it progressed over time for each of the county typologies. If you notice that the working class was the first to see a spike in cases as well as deaths. I did not have the representation of cases in this presentation, but you notice that mortality is increasing for the working class at a rapid pace early on, but then it somewhat stabilized after. It was slow to start in the socioeconomically disadvantaged or in the Southeast. It was slow, but once around July or so, the increase in cases started to accelerate pretty quickly, and pattern was similar in the deprived immigrant counties, which were primarily in Texas, so with the majorly white elderly as well. Please note that the scale is only ranging between 0 to 100 here. And once we did the same plot for the modified version of the county typologies, when we considered the factors that were relevant for COVID transmission, what we saw was really interesting, that the metropolitan urban core was just the outlier here. The blue represents metropolitan urban core. You see how it was drastically increasing early on in May, went on to March, and it went on till May or June, and then it stabilized around early summer. And if you notice, the pattern of COVID-19 mortality among the remaining county types is still holding the same same trend as the previous image. But for the urban working class, we could see the separation or the removal of the metropolitan urban metropolitan core counties has plateaued the trend among the urban working class even more. So in summary, using various county level measures, we were able to identify meaningful county types, more so in two different ways. One is for the traditional SDOH measures where they can be broadly applied to any chronic disease outcomes, but also the modified version of the county typologies, which might be very relevant for respiratory or diseases or infectious diseases that can spread pretty fast. And COVID mortality was high early in the pandemic in the metropolitan counties, but plateaued quickly. Slow but a steady increase in mortality was observed in the counties that was socioeconomically disadvantaged with regards to being either highly populated with non-white populations or in general having low income, low employment, and low education opportunities. The main drawback of this whole approach, or the limitation, I would say, is the fact that we were not able to consider testing, the rates of testing in various counties and how that might have impacted the COVID incidence as well as mortality, the level of detecting the cases. Another important factor is the immunity that the population within a geographic region attains after achieving the infection. Those are things that are hard to control, but it is what it is. We worked with what we had. So we have done this analysis until November, and we have to update the COVID data with the more recent months and the recent spikes that we're seeing around the holiday season to see how the patterns would look like in these county typologies. We would also like to analyze this at a finer geographic unit, that is either a census tract or a zip code, if and when the data is available. And it is still a limitation that we don't have that level of data. We would also like to explore the county typologies separately for each of these census regions, meaning to better characterize the geographic units within the South separately from the Northeast and from the West or the Midwest. And we would like to also explore this clustering using other existing indices that I mentioned early on in the talk that were previously developed by other researchers. So as a conclusion, multivariate indices might provide better understanding of the complexity and the spatial heterogeneity of county level features. And during an infection or an infectious disease pandemic like this, it is very vital to consider community characteristics that could contribute to the disease spread and the effectiveness of control of these measures. And to add on to this, I have to say it was great professionally to grow. This opportunity was unique in the aspect that scientific communication across disciplines can be challenging sometimes, but it was a great learning experience. And this project, which was submitted to the HA COVID-19 Data Challenge, was reviewed by over 30 peer reviewers, and our team was able to achieve second place in the competition. And we plan on putting this forward as a proper publication with more extensive and rigorous methodology. I would like to thank Dr. April Carson because she was there throughout the process without any restriction. She was accessible, and Dr. James Kirkland, who is Dr. Raju's mentor, and he provided valuable input into this project as well. I'd like to thank Informatics Institute and American Heart Association for this unique opportunity. Thank you.